EUS guided antrojejunostomy for malignant proximal jejunal obstruction using a novel modified technique, pushing the boundaries. Endoscopic ultrasound guided gastrojejunostomy is an established procedure for metastatic malignant gastric outlet obstruction. However, its use in proximal jejunal obstruction is rarely described as it is difficult to pass accessories across the structure needed to dilate the target jejunal loops. A 63-year-old female presented with abdominal pain and vomiting for 2 months. She had multiple comorbidities like diabetes mellitus, hypertension, dilated cardiomyopathy. Her ECOG performance status was 2. CECT whole abdomen was done, which showed abrupt narrowing at proximal jejunum just beyond DJ flexure with dilated proximal duodenum with metastatic lesions in the liver. Push enteroscopy had shown severe narrowing with ulcerations in proximal jejunum, biopsy from which confirmed adenocarcinoma. She was deemed unfit for surgery in view of poor general condition. Hence, we did US guided anastomosis for relief of obstruction in this case. We use a standard colonoscope to reach the obstruction site. Then an ERCP cannula over a 600 cm guide wire under fluoroscopy guidance was passed beyond the jejunal structure. Contrast injection confirmed position of the wire deep within the jejunum. Then the cannula was withdrawn. Then a 7 French nasobiliary drain was passed over the wire in its entirety through the colonoscope and was able to reach the jejunal loops distal to the obstruction. Challenge in this case was to maintain the position of nasobiliary catheter during withdrawal of the colonoscope, as the nasobiliary catheter was deeply placed in the jejunum and the length was falling short for exchange. To overcome this, a 9 to 12 mm ERCP stone extraction balloon catheter was advanced over the wire as a pusher with the nasobiliary catheter still in the channel. Then the colonoscope followed by the wire was withdrawn. Nasobiliary catheter was then connected to irrigation pump. Intravenous glucagon was given and 500 ml of methylene blue mixed saline was instilled. Linear US scope was inserted. Another challenge in this case was that the dilated duodenal loop proximal to the obstruction was hampering the view of the target jejunal loop. To overcome this, puncture site in the gastric antrum was chosen instead of gastric body. Once a safe target was visualized, a 20 mm lamps was then deployed in standard freehand method. Distal flange was released under EUS guidance, followed by intra-channel deployment and release of proximal flange under endoscopy guidance. Contrast injection under fluoroscopy confirmed correct stent position with no leak. Reloop gastroscopy after 48 hours showed that the stent expanded well. No adverse events were noted. Liquid oral diet was started next day, followed by soft oral diet after 48 hours. She could resume her chemotherapy, and at 1 month follow-up, she was tolerating normal diet. To conclude, EUS guided anastomosis, though challenging, can be attempted for proximal jejunal obstructions beyond DJ flexure. We need to use a colonoscope with our modified technique for correct placement of nasobiliary drain in obstructions beyond DJ flexure. Dilated proximal duodenal loop may cause difficulty in targeting the distal jejunal loops. Hence, gastric antrum should be chosen instead of gastric body for anastomosis. Thank you.